hyperpara and phagocytoma and the famous Ames syndrome, the apparent mineralocorticoid excess syndrome. This is due to defect in the 11-beta hydroxysteroid dehydrogenase, which is responsible for the deactivation of cortisol to cortisol. Let's go to the second case. She is a 23-year-old patient. She presented with weight loss, nausea, and hypotension. And if you look at the X-ray abdomen of the patient, I will give you a few seconds just to have a quick look at the X-ray. And the question about this case, what's the most probable laboratory finding? Is it low sodium, low potassium, high sodium, high potassium, high sodium, low potassium, or low sodium, high potassium? So I think most of you will agree with me after seeing the X-ray and hearing about the clinical picture of this patient that sodium should be low and the potassium is high. Why that? Because if you look at the plain X-ray of the patient, you see that there are bilateral adrenal calcification. This is one of our patients. This is a true story. And this bilateral adrenal calcification is mostly, at that time, was due to tuberculosis. While the next common cause of bilateral adrenalitis or adrenal atrophy leading to Addison disease is autoimmune. But still, tuberculosis is still in our community, still there. So this is the CT of the same patient, and you can see again in the middle, this is the vertebral bodies. It's full of calcium, of course. It's white. While on either side, there are two adrenal glands that are full of calcium. So this is bilateral adrenal calcification, post-tuberculous adrenalitis, leading to Addison disease with low sodium, high potassium, low blood pressure, and excessive pigmentation. And this is the arrows showing the adrenal calcification on both sides of either side of the vertebral body. These are the adrenal glands calcified. So the learning points about the second case is that primary hypocalcemia are autoimmune as well as tuberculosis. Of course, in our society now we are seeing other causes like bilateral adrenal hemorrhage, particularly that we are using a lot of oral anticoagulant, whether the classic type or the non-classic type, and this can be associated with bilateral adrenal hemorrhage. The third case is a 32-year-old lady presenting with polyuria and severe bone pains for 2 months. And she was 3 months pregnant. We have seen this case almost 2 years ago, and this is a real story, very interesting story. And remember that she was 3 months pregnant. So the first question in this case, what is the least important lab test? Is it to measure serum calcium, fasting blood glucose, serum potassium, or 25-hydroxyvitamin D? Remember, this patient presented with polyuria and severe bone pains. And if you choose that, I will choose for you the least important is 25-hydroxyvitamin D, because measuring serum calcium and blood glucose and potassium is important because they are the important causes of polyuria, because hypopotassemia or hypokalemia will lead to polyuria as well as hypercalcemia, and of course diabetes mellitus. And actually, you have measured serum calcium. It was quite high in this lady. The fasting blood glucose was normal. Serum potassium was normal as well. So the next question, all of the following further steps are important for this lady except one. One is not important. Measuring PTH, doing ultrasound neck, or measuring serum phosphorus, or measuring serum ionized calcium. Remember, the total calcium was 14.5. And I think the least important is ionized calcium, because ionized calcium measurement is usually helpful when there is causes of hypoalbuminemia leading to false low total calcium. So in this case, you measure the ionized calcium. But this is not important in Our Lady because the serum calcium was quite high. And measuring serum PTH is important to exclude hyperpara, neck ultrasonography if you know the cause, and measuring serum phosphorus to confirm primary hyperpara. Actually, the most common causes of hypercalcemia, number one is primary hyperpara, followed by malignancy, inducing hypercalcemia by secreting what we call the PTH-related peptide. Other causes of hypercalcemia in endocrinology include hyperthyroidism, Addison, pheochromocytoma, and vitamin D deficiency, bronchocalciferosis, excessive thiazide, and immobilization for a long time. And we have measured the PTH in this patient with hypercalcemia. It was quite high, phosphorus was low. And this actually will fit with the diagnosis of primary hyperpara. That's why we did ultrasound of the neck, and it shows very well, as you see, a longitudinal view, oval, hypoechoic, well-defined nodule posterior to the lobe of the thyroid. This is typical for parathyroid adenoma. This is the axial cut of the same ultrasound, and you can see that this is the left lobe, this is the isthmus, and you can see on the left side of the thyroid is the internal jugular vein and the internal and the common carotid artery, while posterior to the left thyroid lobe is the left parathyroid adenoma. And if you look at the normal ultrasonography, looking on the left side, you shouldn't be mixed with the esophagus. This is the esophagus, multi-layer, and the saliva. If particularly when the patient is swallowing, you see the saliva giving an echo. And this is the normal left lobe. While on the other hand, the right, this is the right lobe. On either side, there is a common carotid arteries. And you shouldn't miss a parathyroid adenoma, particularly if it's big. But if it's very small, 2 millimeters sometimes is difficult. So 1 month later, we have followed this patient, and because she was pregnant, remember 3 months now, she was on the 4th month, the calcium was shooting up, PTH is increasing, and the creatinine was still normal. Actually, what should you do that? Would you go for surgery or give low calcium diet or giving the calcium mimetics, the cinacalcet or high fluid intake? And I think this particular patient doing surgery is the most important. And the learning points, the primary hyperpara, the most common cause is hypercalcemia, followed by malignancy, characterized by high PTH, high calcium, low phosphorus, and surgery is the main. This is one of our patients with lost lateral part of the clavicle. The fourth case is an 18-year-old presenting with amenorrhea, and the prolactin was quite high. And this is the MRI of her pituitary, and then look at it, and then this is a normal pituitary, you see the difference, and this is 3 months after certain treatment. The prolactin went down, and this is the MRI of the same patient. So what was given? Is it gabapentin, bromocriptine, or octreotide, or none of the above? Actually, it's none of the above, because this patient was typical primary hypothyroidism, was very low T4, very high TSH, and 3 months after thyroxine, everything was corrected. And you can see this is before thyroxine, you get hyperplasia. This is not a tumor, this is hyperplasia with a typical snowman appearance of the cella, and this is after 3 months of treatment. The learning point that before diagnosis of prolactinoma should exclude pregnancy, primary hyperpara, and drug-induced hyperkalemia. The last case is a very short case, 29-year-old female presenting with severe headache, nausea, and vomiting. This is her MRI. If you want to have a look at it. And then the question is, what's the most important lab? Is it the prolactin, cortisol, or TSH, or IGF-1? And I guess most of you will agree that cortisol is important. Why that? Because this patient has got what we call, as you see, this is the apoplexy, a hemorrhage in pituitary adenoma. And this can lead to acute ACTH deficiency, leading to acute hypocorticism. That's why measuring cortisol is life-saving. So remember, pituitary apoplexy, treated with severe headache, most important hormonal deficit is cortisol. And thank you very much for your attention. Thank you for the chairman and for president of the conference, and thank you very much.